off, thanks everyone for coming, and I appreciate the opportunity to talk with you all tonight. Let me know if I'm not speaking loud enough, if you can't hear, if I'm mumbling, anything like that. I want to make sure you guys are here and getting what you'd like out of it. I am going to talk about both shoulder arthritis and its treatment options tonight. The talk itself will probably run around 45 minutes. The hope is to get you guys a good level of detail without boring you to death, but I'm happy to fill in details afterwards, and also that leaves us plenty of time for questions that everyone has. To get started here,
maybe a little bit closer. Would that help you guys to hear him a little? Okay.
Second adrift. I'll figure it out.
Okay.
Is that a little better? Maybe. All right. How about I just project from my diaphragm? Is this a little bit better for people? We'll give it a try. Okay. Let's start by way of introductions. It's kind of silly having a picture of myself up here next to me, but whatever. I am a Portland native. After graduating from high school in Portland, I went East Coast for my undergrad education. Eventually went to the University of Pennsylvania for medical school, followed by my orthopedic residency at George Washington University Hospital. From there, I went to Cleveland, where I did a shoulder and elbow reconstructive fellowship. Those fellowships are where you get your sort of sub-specialty training within your surgical field. And I was lucky enough to have the opportunity to stay on there for a few years as faculty after finishing my subspecialty training. I grew up in Portland, though. I have a lot of family here, and this is where the heart was. So in 2010, I moved back to town. And at that time, I took a job as the orthopedic section chief at the Portland VA Medical Center. I had that job for 6 years before coming over to Rebound last year. In fact, as I think about it, it was actually a year ago to the day that I started with Rebound Orthopedics. And it's been a very nice move. It's been a wonderful place to practice over the last 12 months. So I think that anyone who's giving you a talk like this really needs to make sure that you understand what, if any, financial relationships or conflicts of interest they have with the topic they're talking on. And so these are mine. I'll start by emphasizing that none of my disclosures have any relevance to the talk today. None of them have to do with shoulder arthritis. None of them have to do with joint replacement surgery. I am a co-founder of a very small startup company called Locus Medical Technologies. I intermittently do some consulting for Acumed. I get a small amount of royalties from the Musculoskeletal Transplant Foundation, and I am a partial co-holder of several patents. So the objectives for this talk, we're going to talk about exactly what arthritis is, separated out from some other disease processes like rotator cuff problems, which can also be pain generators for many of us. We'll talk about how it's diagnosed. We'll talk about what the non-surgical treatment options are for it. And then for those people who aren't getting the relief that they need from the non-surgical treatment options, we'll talk about what's entailed in a shoulder replacement surgery, including who might be a candidate for a shoulder replacement surgery and what sort of recovery as well as outcomes a person can expect if they undergo shoulder replacement. Can everyone hear? Is this an okay volume now at this point? Yeah? Okay. So shoulder pain in general. For people over the age of 60, if you look at epidemiologic studies and basic reporting in the society, anywhere, depending on the study you look at, 10 to 30% of people over the age of 60 report some degree of daily or weekly shoulder pain that compromises their overall function and quality of life. And so the shoulder pain often limits our abilities to perform basic activities of daily living. These are things like, putting your cups away up in your cupboard, pushing lawnmowers, all these basic things that you just need to do for life maintenance are affected by shoulder pain. Certainly it influences your ability to do recreational activities that you might enjoy. Tennis, golf, swimming, all these and so many more are going to be problematic if you're having shoulder pain. And then probably actually one of the single largest complaints, and again, if you look at other studies that look at what drives people to seek more extensive intervention, it's most often compromised sleeping. shoulder pain, more than a lot of other joint pains, will actually keep people up at night and make it more difficult to sleep. And so once you stop getting a decent night's sleep because of your shoulder pain, if you haven't yet, you probably are going to go seek the counsel of a physician. So what are the causes of shoulder pain? Some of them actually have nothing to do with the shoulder themselves. You can get a pinched nerve in your neck, which will radiate pain down into the shoulder and sometimes further down into the arm. Sometimes there are obvious traumas that can cause shoulder pain, whether it's fractures like you see with the red arrows here in this proximal humerus fracture, or shoulder dislocations. These are all obvious sources of shoulder pain. But if you look at most people over the age of 50, the vast majority of their shoulder pain is either related to arthritis or it's related to a rotator cuff tear. And we're going to talk primarily about the arthritis component tonight, but we will touch on the rotator cuff element a little bit later on, because these two things do not have to be one or the other, and where they overlap, treatment options may be slightly different. Here we go. So what is arthritis? So in a healthy joint, whether it's your shoulder joint or any other joint, the bone on each surface of the joint is covered with a cartilage surface, and this cartilage is like a high-strength, almost rubbery, resilient biologic material that provides a very, very low friction surface that allows these two sides of the joint to glide past each other and move smoothly and give you good shoulder or other joint function without inflammation and pain. Unfortunately, over time, cartilage surfaces tend to wear out. And the causes of these are multifactorial. Certainly for some people, this is an overuse phenomenon. You're a carpenter, or say you're a person who has spent 20 or 30 years going to the gym and doing heavy weightlifting several times a week. These people just wear out their joints because it's just too much impact loading on the joint surfaces. Evolutionarily, we're not that far away from the time when we all died at age 40. So the cartilage is designed to live that long, and then if you're using it too much, you outlive that cartilage surface. So it can be overuse. For some people, it's trauma, multiple dislocations, a proximal humerus fracture where you fall and break the bones. All these things will adversely affect the cartilage as well, and that cartilage will degrade and die over time as a response to that trauma. However, for the majority of people, there is actually a fairly significant genetic component to developing arthritis. You can be a perfectly good, kind person to your shoulder your whole life. You never abuse it. You never have any obvious traumatic events. And yet at age 60, your shoulder can still wear out for you. That cartilage can be gone. And that's simply because there is a large genetic component to how long your cartilage lasts. And so you can blame that on your parents, and you can warn your children about it, because if you had it, they're going to have it. If your parents had it, you'll probably have it. So those are the causes. In terms of what's the effect, well, as soon as that low friction joint surface wears out, you're now down to the point where you are seeing increased friction, and that friction causes inflammation and pain. And so that's the early starting stages of arthritis. The end result is that once that cartilage surface is completely gone, you now have exposed underlying bone, and you're just rubbing bone on bone at this joint. And this is a very high friction environment. I often equate moving cartilage on cartilage to the idea of pushing an ice cube across a skating rink. These are two low friction surfaces. Everything moves really easily. Once you get down to bone on bone, it's kind of like trying to push a cinder block across your driveway. And it comes with that same grinding, which we call crepitus. It's difficult to do. You feel that friction, which reduces your range of motion and makes it difficult to actually put the arm through the motions you would like to. And all that causes inflammation, which then causes pain. Unfortunately, you can't restore cartilage once it's gone. We can repair torn tendons. We can heal broken bones. We don't have a good repair or restorative process that actually allows us to put living tissue back in a location where you've lost cartilage. And so once you have an arthritic shoulder or any other joint, you have to look for other strategies other than repair or replace. unless that replacement is talking about doing with a non-biologic substance, which are the shoulder replacements or hip replacements, knee replacements, which we'll get into in a little bit. So what does arthritis look like? So hopefully these x-rays are projecting okay. We have on this left side here a normal x-ray of a normal shoulder taken front on. So you're looking at the ball and the socket sides of the joint here. And the things you notice, you have a joint space that's visible between the ball and the socket sides of the joint. This joint space is what that cartilage is filling up. So it's that cartilage that's stopping those two bone surfaces from resting on each other in this x-ray. You also notice that the ball of the humeral head has a nice round appearance to it. You see the same things. These are pictures taken, what's called an axillary view. We actually shoot up through the armpit. So, you know, the hand would be out here somewhere. This is the shoulder joint. The ball, again, you can see a nice round, smooth surface. The socket is a little bit harder to see on this side, but it's this triangle right here. And if you know what you're looking for, you can see there's still a very reasonable joint space there, again, provided by that cartilage surface. Once you become arthritic, this is what that joint looks like. So you don't need to be an orthopedic surgeon to take a look at this and say that there's a profound change that's gone on here, right? So the joint surface has profoundly narrowed down to almost nothing, and that's because you've worn the cartilage surface thin on that joint, and you're getting down to the point where you're bone on bone at that joint. You also notice that you've lost that nice round shape of the ball of the humeral head. It's now sort of flattening out, looks almost like an egg. In addition to that, this doesn't project great on these pictures, but you see this down here. This almost looks like melted streaming wax coming down off the joint. This is an osteophyte or a bone spur, and these are common things that your body will form around the margins of an inflamed joint where it actually puts new bone in places where it's not supposed to be. And that's in response to the inflammation, but can also be a mechanical block to your motion over time as these get worse. If you look down here, this is that same axillary view again, and you see those same changes. You're narrowing the joint space. It's almost gone here. That nice round surface is lost, and you're now flattening out into this sort of elongated oval, and you have some bone spurs that are forming around the edges. So that's what arthritis looks like on an x-ray of the shoulder. So that's what it looks like. What are the symptoms? So most people who present with arthritis have pain, which they will describe as most of the time being sort of deep through and through the joint. Oftentimes people will sort of point to this cleft between your shoulder itself and your chest wall, and it's deep down in here. Sometimes you feel a little on the front and the back of the joint line, or some people actually have it predominantly across the back of the shoulder. But it's usually a deep pain that's kind of through and through the shoulder. Most people have stiffness associated with this because of that added friction, because you've lost that smooth gliding surface and you're rubbing bone on bone. A lot of people can feel the crepitus too, that grinding sensation when you push a cinder block across concrete. You can feel that that's the way the joint is moving once you've really worn out the cartilage there as well. Interestingly, despite the friction, despite the stiffness and the pain, most people with pure arthritis in their shoulder have preserved function. So they may not have full range of motion, they may have pain, but within the motion that they have available to them, they're pretty strong. And that is a pretty classic hallmark of arthritis, at least in the shoulder. So how do you work up when you go to see your doctor, whether it's your primary care provider or your orthopedic surgeon or whoever it might be? How do they work up? How do they first evaluate arthritis of the shoulder? So this starts with getting a detailed history, having you tell them what's bugging you, when does it bug you, point to where it hurts, and hopefully if it's arthritis, that patient is going to report those same things I just described. Well, it hurts with activities of daily living, it's keeping me awake at night, it's this deep pain that's right through here, sometimes I feel grinding with it. That you may or may not report weakness because a lot of people, just the pain will limit your strength to some extent. But the history will be pretty classic. You then look at the physical exam, and that physical exam is going to show that most people have lost some degree of range of motion in all planes, and that means you may not be able to get these arms all the way up over your head again. If this is normal for you, maybe you only get up to here on your arthritic side. You can't roll the arms all the way out to the side, so if this is normal for you, maybe you can only get your arm out part way. and also restricted motion coming onto your back. You know, you used to be able to scratch the middle of your back, now you can barely tuck in your shirt. So these are all things that you're going to see on physical exam, but you're also going to notice that when they check you on physical exam, you have some pretty decent strength and you can push as long as you're sort of down here by your side. And then they're going to follow this up with some x-rays. And the x-rays, for the most part, are usually all you need, combined with that history and physical exam, to properly establish the diagnosis for 90–95% of people. So, you know, these are not the same x-rays that I showed on that previous slide, but nevertheless, you can see those same hallmark changes, right? You have a little bit of a joint space left up here, but you can see down here there's no daylight left between the ball and socket sides of the joint. This ball is no longer a ball, it's more like an egg, approaching maybe even a square peg in a round hole. You can see this bone spur forming down here, so these are all arthritic changes, and this combined with your history and physical exam tells you what's going on. This same x-ray, or excuse me, the same shoulder taken as that x-ray up through the armpit actually shows you this is a pretty severe form of arthritis, because once you've stopped wearing away the cartilage, if this keeps going, the bones can start to wear each other away too, the same way two river stones will polish each other over time. And so what's starting to happen here is this ball is actually starting to slip out the back of the shoulder. The socket is right here, and it should be a flat triangle, but here's the front of the socket, and you can see the ball is starting to actually wear a scalloped divot into the back of the socket right here. And so if you're starting to see something like this, or if you're to the point where you're talking with a surgeon and there's some consideration that maybe surgery could be necessary for you, at that point you're likely to move on to some additional imaging studies, usually a CT scan, which is basically very similar to an x-ray but allows you to get a much more detailed three-dimensional image of the bones. And this is a CT scan of this socket up here. And again, the socket should be almost a perfect triangle right here, but you can see this is that scallop where that humeral head is eroding away the back half of the socket. You're still going to have surgical treatment options for this, but it is going to require some additional sort of modifications of implants and some, you better have a surgeon at that point who does more than just a couple dozen of these a year, because this one's going to be tricky. So that's the x-rays and the CT scan. It's not usually necessary to get an MRI. MRIs are good for looking at soft tissue. And as we've been talking about so far, arthritis is mostly a problem of bones. However, that rotator cuff that we referred to earlier, that's that first sleeve of muscles and tendons that surrounds the ball and socket joint. And a properly functioning shoulder requires not only cartilage in the joint, but it also requires an intact, functional soft tissue envelope around it to properly balance the push and pull of the mechanics of the shoulder. And if there's some concern that you may have problems with your rotator cuff, that is going to significantly impact the treatment options for the shoulder, even if you do have arthritis. And at that point, you're going to look for an MRI, because that MRI will allow you to look at the soft tissues in a way that the x-rays and the CT scan can't. So, how do you start by managing arthritis? There are a lot of options, and you really should run through the majority of these before you move on to anything else. It starts with establishing the proper diagnosis and making sure that the patient's properly educated. There's always a goal of maintaining the strength and function you have so it doesn't decline more. Judicious use of non-steroidal anti-inflammatories can be effective for this for some people. You may or may not want to consider steroid injections as another option to modify pain and inflammation in the shoulder. And then there are some other options which intermittently come in and out of fad, which may or may not have some true efficacy behind them, but for which, frankly, the medical literature is still undecided. And those include things like viscosupplementation and nutritional or dietary changes. So we'll run through each of those in a little bit more detail. So first, as far as the maintaining strength and function, not to put the cart before the horse, but if a person gets to the point where they need a shoulder replacement, one of the important messages about shoulder replacements is that my own personal experience, as well as an abundance of orthopedic literature, shows that shoulder replacements are superb at alleviating pain. They are highly unpredictable at their ability to regain additional motion that you've lost, which means if you get to your day of surgery for a shoulder replacement, your range of motion is to here, barring something unexpected as far as an outcome, you can anticipate you're going to get all that motion back after surgery, and you'll probably gain some. But whether you gain 10 degrees or 50 degrees is really hard to predict. That also means if you get to surgery and your range of motion is only to here, you're not going to get up to here again, almost no matter what, which means your starting range of motion going into surgery, and therefore how well you've preserved your motion and function leading up to surgery, is going to have a direct determination on how good your range of motion and function is after surgery. Another reason to keep this up is because, as is true in much of orthopedics, this is a use it or lose it phenomenon. You may have a shoulder that hurts and is stiff, but if you're putting it through a range of motion every day, those muscles are going to stay strong, they're going to stay fit, you're going to be more active as a whole, and your muscles will continue to be able to perform that function. But just like any other exercise, if you're not putting that shoulder through a range of motion every day, those muscles that aren't getting exercised are going to get weaker every day. And you compile that on top of the friction that's associated with arthritis and the pain that's associated with it, and all of a sudden you can lose function very quickly if you're not keeping it going on a daily basis. So this can be done in large part just by being good about maintaining your own activities of daily living, whether it's being diligent about doing chores, even doing the stuff where you need to reach overhead and it hurts but you can do it, or whether it's mowing the lawn, or whether it's going to the gym on your own. All those things are good, and you're probably helping yourself by keeping that function going, even if you're causing some additional pain. You can also sometimes, especially in the more severe cases, you may seek, or your doctor may ask you to go see a physical therapist who can help direct you for some more specific exercises, both to maintain range of motion with stretching, or to help you with some basic strengthening activities to preserve the strength that you have. So how about non-steroidal anti-inflammatories? These are things like Aleve, ibuprofen, naproxen, naproxen, Celebrex, Mobic, all of these things, okay? So the medical literature out there shows that these can be highly effective for some people. And I certainly have patients who have x-rays that look terrible with respect to arthritis, but they say, listen, as long as I am taking my non-steroidal anti-inflammatory on a regular basis, I have very little pain, they're happy, they function okay, and they keep going. And then as soon as they go off, the pain comes on and they have problems. So some people actually are clearly seeing a great benefit for non-steroidal anti-inflammatories. But the medical literature shows that it's highly variable and unpredictable who is and isn't going to respond. You can have two perfectly reasonable people with the same degree of arthritis. One of them will get a lot of benefit from using a non-steroidal. The other one can take it and they're not going to feel any symptomatic pain relief. There's no way to know except trial and error. It's worth trying. For the most part, these are fairly safe medications with a low complication risk and low or a good safety profile. Certainly preferable to taking things like narcotic pain medications. But you guys just got to try it and see if it's going to work for you. It is worth pointing out, there are basically two classes of these. They're the more traditional non-steroidal anti-inflammatories. These are your ibuprofen, Aleve, naproxen, naproxen, that sort of thing. These are non-selective NSAIDs. They have a broader reach in terms of what parts of the inflammatory pathway they hit, but their downside is that they also are more likely to cause stomach ulcerations, and so you can get into some GI problems with these if you're taking them over the long term. So you do need to be attentive to that. You need to stop these if you're taking them and you're starting to get like acid reflux type symptoms. And if you're taking them over the long term, you should probably consider being on a gastroprotective second medication. These are like the PPIs. These are proton pump inhibitors, things that basically help modify how much acid you have in your stomach so you don't eat away the stomach lining. The second group of these non-steroidal anti-inflammatories are called the selective NSAIDs, often referred to as the COX-2 inhibitors. These are things like your Celebrex, your Mobic, okay? Now these have a lot less GI irritation and they're not likely to cause stomach ulcers. Unfortunately, they have been shown to have a significant risk of increasing the possibility of having a cardiac-related event, especially if you have a pre-existing problem with coronary artery disease or a prior heart attack, or if you've had stents or something like that. So you need to be careful about the potential cardiovascular implications of taking these COX-2, even though they're safer for your stomach. So steroid injections. Steroid injections have been tried and true in orthopedics for several decades. They tend to be pretty reproducible as far as at least transient pain relief for arthritis in the shoulder, as well as in other joints. And some people will get only a month of symptomatic relief, which is unfortunate. Most people will see 2-3 months of relief. Some people will see a year's relief from a single steroid injection. The problem is that their efficacy does seem to decrease over time. So you may get your first couple and they each last 6 months and you're feeling great, but the third injection you get lasts 6 weeks instead of 6 months, and if you were to go for a fourth injection, it only lasts a week. So efficacy decreases over time with these. The other problem is that there's mounting medical evidence, and it's not in dispute now, but we're just really still sort of defining how much this occurs. Repeated use of steroids over time do degrade the tissue quality in the area where they're being injected. So these steroids work by suppressing inflammation, which is why they give you pain relief. But inflammation is also your body's first stage in the healing and repair pathway. So if you're constantly suppressing your body's healing and repair pathway in this area of the body, then what happens is all these microscopic injuries that you accumulate on a daily, weekly, monthly basis never have the opportunity to repair themselves, and over time the tissues become degraded, moth-eaten, the bone becomes more soft, and now if and when a surgical option is required, the tissue you have to work with is badly compromised and may actually influence your ability to do the procedure and get the best possible outcome. So there are downsides to these steroid injections. I typically have a hard and fast rule of no more than 3 steroid injections in any one 12-month period of time for any given body part. I prefer to limit it to less than that. And I really start to cringe if I'm giving 3 injections a year, 2 years in a row. So these really should be minimized. So viscosupplementation. These are another form of injections that you can get into the joint. They've been most popular with respect to knee arthritis. These are things, and I'm sorry, not at all readable here, but these are things like you may have heard Synvisc, Hyalgan, Supartz, Orthovisc, Euflexa. These are basically, they are hyaluronic acid compounds, which is a complex macromolecule that is very analogous to some of the components of your cartilage and your own joint fluid in your own joint. Some of these are derived from crazy things like the coxcomb on a rooster. And there has been a lot of money, a lot of effort invested into marketing these to the general public. They are incredibly expensive, and their efficacy is highly questionable after many, many years of research. They're safe. They have a good safety profile. I see no reason not to give them a try, assuming you don't mind spending the money and assuming you don't mind the needle in the joint. I think there probably is a limited role for these in some types of arthritis and in some types of people. I know some people, I know some orthopedic surgeons, I know some nurses in the operating room who swear they get one of these injections every 6 months, and it's been keeping them going with known arthritis in their knee for 5 years, and I believe them. The problem is it's probably only a very small subset of joint arthritis that responds positively to these, and it probably works better in those people who are in that very, very early stage of arthritis and who are not yet in the moderate to end stage arthritis. And so the problem is, at least for me as an orthopedic surgeon, most of the time by the time someone's showing up to my office for shoulder pain, they've missed the boat. They don't have early arthritis. They're in the moderate to sort of end stage range of arthritis. And if there was a role for this, it's probably come and gone. That said, as I said, fairly safe in terms of their complication profile. It's not unreasonable to try them if you're running out of other options. Finally, nutritional elements. So glucosamine and chondroitin, another thing you can buy off the shelf. A lot of commercials about it. Relatively expensive, or at least it used to be until the market was flooded with them. Now you've got a million different options. Some people swear by it. All the studies show it's exactly as good as placebo. That said, If a sugar pill or glucosamine and chondroitin sulfate makes you feel better, why not take it? So again, worth a try. The evidence would suggest it's no better than taking a sugar pill or something else that's just generic. And then, some people swear by other things. Turmeric is something that has been touted for its anti-inflammatory properties. My working partner in crime, Tim Black, who's my physician assistant, pointed out to me today that cloves are a popular one. So he suggested sprinkling turmeric and cloves over whatever you eat tonight, and that might help. It's reasonable to try these things. They may or they may not work for you. There's nothing proven about them as far as their use, but they're safe to try. So if you've run through this list of options that we've gone through, and you still have functional limitations or pain that's limiting the quality of your life, you are at that point where, at least in my hands, you've exhausted all the non-surgical treatment options. And at this point, it is very reasonable to talk about moving on to surgery, and that surgery in my hands is a shoulder replacement. So, we have this picture of the arthritic shoulder here, which you recognize. It's lost the round shape. It's lost the joint space. You have a bone spur down here. So a joint replacement, this would be a fairly typical joint replacement that we might use. It's a titanium stem with a cobalt chrome head on top and a high-strength plastic socket that's referred to as ultra-high molecular weight polyethylene. These are all materials that have been implanted within the human body for several decades. They all have excellent safety profiles. It is exceedingly rare for anyone to have rejection problems or issues with these. The only caveat being those people who have a documented metal allergy, usually to nickel, where say they can't wear cheap earrings or jewelry. Those people, there is a nickel component in cobalt chrome. There is a lesser, but to some degree, a nickel component in most titanium alloys. These people may have to consider alternate bearing surfaces, which are out there. But true nickel allergies or metal allergies that cause problems with these are incredibly rare. And these are materials that have been tolerated in the human body reliably in many different locations and situations for a long time. So you take one of these shoulder replacements, and during surgery, we actually cut off the ball of the humeral head coming right across here. We drop that stem down the long bone of the arm. The new cobalt chrome ball goes on top, and then the high-strength plastic goes on the socket. And when you're done, it looks something like this. If you go back and you remember what your original shoulder looked like before it developed arthritis, I'm still amazed at how faithfully you can reproduce what looks like pretty normal anatomy with proper choice of components. You can see that joint space is back again, admittedly given back to you by plastic that's filling the space, but you're keeping the to bone off of any other bearing surface. You have a nice smooth round ball to the humeral head. Everything's lining up just the way it should. And these usually are superb and reliable for pain relief, and they should at least preserve the function you had going into surgery, and for many people it will give them some improvements in range of motion. So let's step back and talk about joint replacement surgery in more generic terms briefly. So joint replacement surgery has, in the literature, been very thoroughly and repeatedly shown to be a definitive and the best treatment option when it comes to end-stage arthritis of any joint, whether it's a hip, a knee, or a shoulder. It sounds a little bit like exaggeration, but if you actually want to go out there and look, you can find these economic studies. There's a whole field of healthcare that looks at the economics of the value that's attained from doing certain surgical procedures or certain medical interventions. And when you take the economic cost input to the improvements that patients get after surgery, as well as their reported satisfaction with the outcome, it's pretty incredible to recognize the fact that hip replacement surgery and other joint replacement surgeries in orthopedics have actually been shown economically to be the single most successful medical intervention in the history of medicine. And that's why there's almost 1 million of these joint replacements done in the year just for the hip and knee, each year in the United States alone. That's just hip and knee replacement, right? So that doesn't talk about shoulder, doesn't talk about any of the lesser joints. So that's about 2.5% of the US population every year is getting a hip or knee replacement. And the only reason those numbers are that high is because surgeons have found it's a reproducible surgery, and the patients keep coming back because they're satisfied and are looking for this procedure because it's getting them what they want. So if you look at shoulder replacements are actually only 1/10 of the volume in the United States in recent years. So for every 9 hip or knee replacement surgeries, you're only doing 1 shoulder replacement surgery. And there are several reasons for that. Fundamentally, this might come back to the fact that the shoulder is a different kind of joint. The knee is functionally a hinge joint. The hip is functionally a deep ball and socket, sort of trailer hitch type joint. These are both inherently mechanically stable joints right from the get-go. That means that from a sort of implant design philosophy, they are fairly easy to figure out, not to minimize the incredible work that's been put into developing these procedures over the decades. But we've been putting hip and knee replacements in patients with relative frequency ever since the 1940s, 1950s. Shoulder replacements really didn't start until the 1980s. And so that lag of several decades in part accounts for why there has been such a mismatch in the number of shoulder replacements versus hip and knee replacements in the United States. And one of the reasons shoulder replacements have been slower to come along is because, unlike the hip and knee, the shoulder is not an inherently constrained joint. The ball and socket stay next to each other only because the surrounding soft tissue envelope keeps it there. And that's again where this rotator cuff element comes in that we'll touch on again in a minute. But that makes it more difficult to properly design and frankly properly do a shoulder replacement, because you can't just put these parts in and expect them to be inherently stable and functional. The shoulder replacement is often referred to as a joint replacement that's a soft tissue procedure, because if you don't get the soft tissues right, it doesn't work for you. So we're only doing 1/10 the number of hip and knee replacements in the United States every year that shoulder replacements that we're doing hip and knee, but the trend is interesting. So in 1992, there were 12,000 shoulder replacements done in the United States. 10 years later, that number doubled to 25,000. 6 years after that, it had doubled again to 50,000. And 6 years after that, in 2014, it had doubled again to 100,000 cases. So you can see what this trend line is. And again, this trend line only exists because we're figuring out how to do these effectively, and patients are happy with what they're getting, and so they're coming back and asking for a second shoulder replacement if they've already had a first and their other one's bugging them, or their friends and family are realizing that they got a good fix to their arthritis in their shoulder and they're seeking a similar intervention. So far I've just been showing you this, what we call an anatomic shoulder replacement. And I kind of pointed to why this is an anatomic shoulder, right? It's because the new parts look anatomically like your God-given parts, just rolled back a few decades to before they got all worn out. But there are actually 2 types of shoulder replacement that might be used if you have arthritis. And the second type is called a reverse shoulder replacement. And that reverse shoulder replacement is called the reverse shoulder replacement because it puts a new ball or hemisphere on the side that used to be the socket, and it puts a new socket on the side that used to be the ball. And this has been yet a newer advent. These only came onto the market in the United States in 2006. And they have a longer track record in Europe. But these reverse shoulder replacements are used when you have a combination of arthritis and a rotator cuff problem. And you obviously don't need to know which one you have. That's for your surgeon to talk with you about. But it's important to know that there are 2 designs, because what actually happens on the day of surgery is going to be about the same for the patient either way. But functional expectations, longevity of the implant, these things are slightly different from design to design. And I wouldn't bore anyone with the details here, but it's important to know there are 2 types, and then follow up with whoever's your surgeon taking care of you if you're talking about a joint replacement, to understand which type you're getting and why. So 30% of the population over the age of 30 has arthritis. 40 to 60% of the population has a problem with their rotator cuff. These people in yellow are the people getting the anatomic shoulder replacements. These people in orange are the ones getting the reverse shoulder replacements. And in fact, we won't go into it in any more detail, but for large, non-repairable rotator cuff tears, even in the absence of arthritis, we're starting to see more and more people who have no arthritis, but an otherwise unmanageable rotator cuff tear in this red zone. They can be candidates for joint replacement, for shoulder replacement as well. So just to give you a little bit of context to understand where the arthritis and the rotator cuff fall into things, brief look at shoulder anatomy. So this is the shoulder blade, the scapula with the socket, and the ball, the humeral head right here. So this is the shoulder joint. You know, the red and white, this is the part that wears out when you get arthritis. You've lost the cartilage, you're now down to bone on bone. The next layer out is the joint capsule, which surrounds the ball and socket joint when you look at it from the front, the side, and the back. And then over top of the joint capsule is that first layer of muscles and tendons. This is your rotator cuff. So your rotator cuff covers the front, it covers across the top, right up here, and it covers in back. I wonder what that was. All right, there we go. Let me go back a slide. Right, so it covers front, top, and in back. So this rotator cuff is that first sleeve of muscles and tendons that surrounds the ball and socket joint. And you can either have arthritis, you can have a tear in your rotator cuff, which will show up here, or you can have both. Over top of your rotator cuff, you then have all those bigger muscles that we kind of see on the surface. Your pectoralis on your chest wall, your deltoid on the side, your biceps, your triceps running down the arm. Okay? So those are the layers of the muscles and the bones that surround the ball and socket joint. So I know most people don't want to get into the biomechanics. I'll do this one last thing, quick and dirty. The reason this rotator cuff is important to figure out what type of shoulder replacement you want is because your deltoid does, which is this big muscle on the top surface, does most of the driving and gives you most of the strength to raise this arm over your head. But when the deltoid contracts, all it really wants to do is pull your arm straight up, which if you don't have a functional rotator cuff, means you do this. Okay? If you have a functional rotator cuff, though, however, when your deltoid fires, your rotator cuff fires in conjunction with it, and the competing pull of those muscle groups creates a pivotal force and rotation that occurs around the center of that ball and socket, so that when they fire in sync, the ball of the humeral head pivots and the arm raises up over the head. If our slide advances. Right. But without that rotator, so if you have a functional rotator cuff, you can still create that fixed center of rotation around the ball. You get an anatomic shoulder replacement. If you have a dysfunctional rotator cuff, then when you try and fire your deltoid, the ball just goes straight up instead of pivoting. You have no fixed center of rotation, so you need a reverse shoulder replacement. And I really will spare you the details on this, but trust me when I say that inverting the geometry of the ball and socket reestablishes that fixed pivot point around the center of that shoulder up top and allows you to regain that ability to bring that arm up over top of your head. Okay, so if you're considering a shoulder replacement, when do you consider it and who's a good candidate? So first off, you should have a diagnosis of arthritis, or not to be talked about too much here, but for some people with massive non-repairable rotator cuff tears, you might be a shoulder replacement candidate. You need to have pain that's compromising the quality of your life. As I said, most of these shoulder replacements will give you some improvement in range of motion, but their real bang for their buck is pain relief. And if you're not having pain, you better think carefully about whether or not you're a shoulder replacement candidate. And you really should have exhausted at least the majority, maybe not all, but the majority of those non-surgical treatment options on that list that I gave earlier before you consider moving on to a joint replacement. So who? Anyone over to the age of 50. We don't like to put these in people younger than 50. We think these joint replacements, we know these joint replacements have, on average, probably about a 20-year life expectancy. That doesn't mean that if you're 50, we're betting on you dying by age 70, but it means that, as we get older, even if we're still very physically active, we tend to slow down a little bit. We tend to be working a little bit less hard in our jobs. We're more likely to get more lifespan out of that joint replacement. And you know what? If I put a joint replacement in you at age 55 and you wear it out at 75, chances are, if you're unhappy with that function at 75, I can revise that joint replacement and give you another one, and that second one will last you until you're 100, and then we're probably good to go. But if you get your first joint replacement at 40, it's not going to last till 60, it's going to last till 55. And then you're going to be getting your revision at 55, you'll be getting your second revision at 65, you'll be getting your third revision at 85, and we'll stop there. So, anyone over the age of 50, and I would point out, while it's not routine to do these joint replacements in people in their mid-90s, your functional level and your physiologic age is a lot more important to me than your chronologic age. And I have had very fit, healthy, vibrant 95-year-old people who have come into my office and be surprised that I told them I thought they were a shoulder replacement candidate. And frankly, it's because they look healthier and they're more active and they're sharper than some of my 75-year-olds. So it's really about whether you're healthy, not how old you are. These can safely be put into anyone as long as you are healthy enough and have the right criteria as far as pain and exhausting non-surgical options, and you're at least 50 years old. You really don't want to do it before then unless you're absolutely in dire straits. So other than that, you need to have your medical conditions properly controlled. Most importantly, things that tend to influence this, diabetes control is incredibly important. We know that people who have poorly controlled blood sugars are much more likely to get stiffness after shoulder replacement. Obviously, we need your heart to be in good condition. That's more due to the physiologic stress of the anesthesia than the actual surgery itself. You want to make sure that your lungs are in good shape, that you don't have COPD, that you don't have asthma. These things, again, more relevant to your anesthesia risk than the actual risk of the joint replacement, but these things need to be dealt with. Important to any joint replacement, you need to have any dental issues sorted out. We're putting metal and plastic in a human body. Bacteria love to glom onto and grow on any non-living, non-biologic material in the human body. And if you have an infection anywhere in your body, teeth being a common place to have a dental, carry a dental infection, that infection can spread through your blood, latch onto the shoulder replacement or the joint replacement in your knee, set up an infection there. That's a big deal. So before anyone has a shoulder replacement surgery, you should really get your teeth checked out carefully, make sure you don't have any active cavities. And if you do have cavities, you should delay your shoulder replacement surgery or your hip or knee replacement surgery until you get that tooth extracted or the cavity dealt with. So you've now decided you're a good candidate for a shoulder replacement. It's something you've decided you'd like to go ahead with. What do you do before surgery? Well, there are certain things you really should talk with your surgeon about. First off, you should be clear what your goals are. If your goal is restoring your range of motion from here to here, and you have standard arthritis, your surgeon may be able to deliver that, but if they tell you they can promise they can deliver that, they're either a whole heck of a lot better than me, which admittedly may be true for some people, but more likely they're rolling the dice, because the best surgeons in the world can't reliably predict how much improvement you're going to get. You'll get some improvement, but whether it's from here to here is unpredictable. What I can predict is that your pain is going to be dramatically better. And so we need to talk with you about your goals before surgery so that I know that your goals are realistic for what I know I can deliver with the type of shoulder replacement we're talking about doing. Other things, you should talk about your surgeon's expectations, and what I mean here is that to get a good outcome after just about any shoulder replacement surgery not only requires that the right thing be done on the day of surgery, but it requires a significant investment in physical therapy, which only you can really do after surgery. You can work with a physical therapist, you can have your surgeon telling you what your exercises are that you need to do, and obviously they'll be doing that. But for these shoulder exercises, most of them are best done in 5-minute increments, 4 or 5 times a day. And if you're not engaged in that process, you're probably going to get a bad outcome from your shoulder replacement surgery because, as I said, shoulder replacements are a soft tissue procedure. And so you can put the right joint replacement in there, But if the soft tissues aren't rehabbed properly afterwards, you're not going to get the outcome you're looking for. So surgeons' expectations as far as your rehab and what you're allowed to do at various stages after surgery is incredibly important. The other thing I would ask the surgeon is what their surgical team, his or her surgical team's experience is. That is to say, is this a surgeon who puts in 10 a year, or is this a surgeon who puts in 100 a year? You do not need someone who has shoulder and elbow reconstructive fellowship listed on their, on their CV, on their resume. It doesn't matter whether or not they trained at a good place and trained to do this. But there's good evidence out there in the medical literature that shows that those surgeons who put in at least 50 shoulder replacements a year and those hospital systems that put in at least 50 shoulder replacements a year consistently deliver better outcomes for their patients than surgeons and hospital systems that put in fewer. So if you can have a wonderful orthopedic surgeon who does wonderful work, if they're only putting in 20 of these a year, you might at least want to go talk to someone else who puts in more, because the statistics would suggest you're likely to get a better outcome with that person who does a higher volume. I'm a one-trick pony, but I've learned how to do my one trick well. I have a few other tricks, but you get the point. So you obviously talk with your surgeon, you go over these things. You make sure you're medically optimized, again, speaking to the diabetes, the cardiovascular, the pulmonary, dental issues, all those things. Hopefully, if you're with a surgeon who does these on a routine basis, either the surgeon's practice or the hospital that the surgeon collaborates with will also have a preoperative joints class. And this is basically a session that you go to with other people who are being signed up for joint surgery, where you get to meet with nurses and other practitioners who are part of the team that's going to take care of you in the hospital. And they can give you a detailed booklet that goes over all of the important questions that most people have about what this surgery is that's coming up, how you prepare for it, things you should expect, things to do, things to not do. These joint classes, as a general rule, I think do improve the outcomes from surgery, and they also do a lot just to reassure and allay the patient and the patient's family about what they're getting into, because a lot of the anxiety about this is just not knowing what to expect, and these really help with that. Finally, prepare your home environment. If the only thing you will ever eat in the morning is cereal, and your cereal is on a shelf up here, you're not going to be allowed to lift up here to get your cereal out for the first 4 weeks after surgery with me. So you better move that cereal down to a different shelf. If your family typically relies on you to do all of the laundry, time to tap someone on the shoulder and tell them it's time to step up, because it's not great to have you carrying around laundry baskets up and down and loading things in and out of the washer and dryer for that first couple weeks after surgery, at least. So, prepare these things at home, anticipate what your restrictions are going to be after surgery for a little while, so that you are not caught off guard by that and get home to a home environment that you're not comfortable or not happy in. So on the day of surgery, no food or drink, midnight before the day of surgery. That's so you have an empty stomach. That includes water, although you can have a sip with several pills. Your anesthesiologist, your orthopedic surgeon team is going to review with you which pills you should and shouldn't take on the day of surgery. And then just before the surgery in the preoperative holding area, you're going to meet your nursing team, you're going to meet your anesthesia team, and you're going to meet your orthopedic surgeon. Again, obviously, you better have met this person at least once or twice before you get to the day of surgery. But the team is an important element here, and it speaks to the fact that, it's related to the fact that you see better outcomes in hospital systems and surgical teams that do larger volumes of these on a consistent basis. This doesn't work well, it doesn't work optimally unless you have a whole team around you, all of whom knows what they're doing, and they do it together on a routine basis. So, you go back to the operating room, you go to completely asleep. You may or you may not get a nerve block at the time of surgery. Some people get a nerve block that leaves them with a numb arm for about the first 12 to 24 hours after surgery. It's not necessary. Some people get it, some people don't. I actually deal with this on a case-by-case basis. Some patients are going to benefit from it, but there are downsides to a nerve block, so I talk about that with each patient. But whether you get a nerve block or not so that your shoulder and your arm are numb, you're going to go completely to sleep for this surgery. While you're asleep, we're going to use an incision across the front of the shoulder that runs from here to here. Through that, we're going to give you a new ball. We're going to drop a metal stem down the long bone in your arm. We're going to give you a new plastic socket. It's all going to be done through this one incision in the front. Surgery is going to take about an hour and a half to 2 hours. It's going to feel like about 1.5 seconds to 2 seconds to you, because last thing you're going to remember is the anesthesiologist counting down from 10. Next thing you know, you're going to be waking up in the recovery room and it's done. So after surgery, most people do stay one night in the hospital after surgery and go home the next day. In some rare circumstances, and it's probably only about maybe 10%, maybe 15% of my patients, a patient may stay longer, and that's either because we need to do something to optimize their other medical conditions, or maybe they also have issues with walking and we just don't think they're going to be safe and stable going home on their own. So some people stay longer, but most people only stay one night, and they're looking and feeling up to going home the next day. Select patients may in fact be a candidate to have this done as outpatient surgery. In the United States, these started being done as outpatient procedures for the first time about 3 years ago. Rebound and Peace Health with our outpatient surgery center here started about 1 year ago with an outpatient total joints program. It started with our hip replacements, moved on to knee replacements, and we're now doing shoulder replacements. It is a relatively small percentage of our patients, and that is both because we want to make sure that these are patients who are in every way, shape, and form absolutely going to be safe going home on the same day. It is frankly in part because insurance companies haven't caught up with current standards of potential care. The reality is that if it's the right surgery to do as an outpatient, these actually tend to cost the healthcare system and even the patient less to do as an outpatient than they do to do as an inpatient. And I can tell you, across the board, every single person that our organization, our group has done as an outpatient, whether it's a hip, knee, or shoulder replacement surgery, has been absolutely thrilled with it, and they've had great outcomes. So it can be safely done as an outpatient, but it's still a relatively rare thing. Whether you're with me or some other surgeon at some other practice, they may talk with you about whether or not you're a candidate. It's something worth considering. Oh, I would also point out this get up here. So patient resting in a sling, you don't need to live in that sling. The shoulder needs to be treated gently for the first couple weeks after surgery, but it's not going to fall off if you take it out of the sling. And in fact, I encourage people to take it out of the sling starting immediately after surgery. The sling is really just there for comfort. If you're trying to be out of the sling for 12 hours a day, the arm's going to feel sore and heavy. You're going to want some support, so you put it in there when you need it. But I encourage people to spend more and more time out of the sling. Most of my patients are not wearing the sling by the end of the first week, except maybe when they show up at their clinic appointment because they want to look like they're being really good, and so they wear their sling when they show up. Other people, these cooling units for the shoulder are excellent too. There are a couple of different ones on the market. Not everyone wants them. Not everyone has to have them. Unfortunately, they do tend to be an out-of-pocket expense, which can be annoying for some people. But basically, this Igloo water cooler has tap water and a bunch of ice in it. It's got a little motor on the top and an insulated tube that runs up here. So you push go on the top of that, and this continuously circulates ice water through this pad up here on your shoulder. Unlike that ice pad that melts and sweats on you, this doesn't melt and sweat. Unlike the ice that you just put directly on, which you should only leave on for 20 minutes at a time, this is calibrated so that you can leave it on continuously. I have people who love this and will wear it for 23 hours a day for the first week after surgery. And then, after that, they'll back off and maybe they'll wear it for like an hour after they do their exercises, as things go on. But something to think about, can be very helpful with pain management, helps with swelling some as well too. So what are you going to be doing as far as activities in your physical therapy? From post-operative day number 1 up to the first 4 weeks after surgery. As I said, sling is for comfort. You don't have to wear it, but it's there to support the arm when you want. Lightweight use of the hand and wrist is allowed at waist level right from the get-go. I tell people a 1-pound limit. That means you can do things like button your shirt, hold a book, lift a fork to your mouth, all those things you can do starting day 1 after surgery. I don't want you lifting, pushing, reaching, pulling. I don't want you carrying more than 1 pound of weight in that arm, But for those lightweight, non-resistance things that are just right here using hand, wrist, elbow, those are safe to do immediately. In terms of your physical therapy, I already talked about the fact that really being engaged with your own physical therapy is incredibly important to optimizing your outcome. The good news is the whole physical therapy routine, at least for me, is only about 5 minutes of stretching at a time. And these exercises at first are going to be uncomfortable, but it's only 5 minutes of discomfort and then you get to stop. The key is you should be doing them 4 or 5 times a day, every day. And that's why you don't need to see a therapist early on, because you're not going to find a therapist who's willing to come to your house for 5 minutes every 4 hours for the first 4 weeks after surgery. If you're not willing to do it on your own for those 5 minutes every couple hours while you're awake, it's not going to get done. But it's quick. It's really just 2 or 3 stretches where you either roll the arm out to the side or you use your other arm to help stretch yourself up over top of your head. And you're working on those, just getting back a little bit more range of motion every day for the first couple weeks after surgery. At 4 weeks, we transition to a little bit more vigorous physical therapy protocol where we now start letting you strengthen the shoulder. At this point, your physical therapy may be a little bit longer, not 5 minutes at a time here or there, but you can do half an hour, 45 minutes a day on it for the most part and get it done. So now's a good time to see a therapist. And that therapist will both continue with some stretching for you to work out any residual stiffness you have and add some strengthening exercises to start building back your rotator cuff. Again, shoulder replacement surgery, it's for arthritis, but you can see my talk keeps coming back to that soft tissue envelope in the rotator cuff. So they add strengthening, and you'll often see a therapist once a week. They'll guide you on the exercises, but there's still exercises that you're going to be doing on your own every day. You don't need to go see the therapist every day. You see the therapist once a week. You do your own exercises that they've taught you the other 6 days of the week. You check back in with them next Monday, that sort of thing. During this time, now that we're allowed to start strengthening, you're allowed progressive return to all activities of daily living. You're not going to be able to raise your arm up over your head on week 4 plus 1 day because these muscles are out of shape, so they're weak, and they're going to take a couple of weeks of strengthening up to get to the point where they're strong enough to bring your arm up overhead again. But you're allowed to start those activities and work towards that starting after 4 weeks after surgery. And as you see improving in strength and endurance, you're allowed progressive activities and basically, as tolerated, advance back to additional range of motion, including overhead activities. I'd say on average, most of my patients feel like they're hitting their stride somewhere between the 3 and the 4 month mark after surgery. That's the point at which they feel like they've regained their strength, they've regained their endurance, they feel like they have the range of motion or better than what they had prior to surgery, and their pain is negligible, if there at all. I do have some patients that are well ahead of that curve. I have some patients at 6 weeks who are doing this and tell me their pain's gone. But you should be anticipating that you're going to need to invest 3 to 4 months in this before you really feel like you're hitting your stride. And in fact, if you look carefully, most people are actually improving all the way out to 1 year after surgery. The functional improvements in the strength are subtle the further out you go, but delicate testing will actually show that people are continuing to improve well past that 3 to 4 month mark after surgery. So again, 3 months after surgery, that's when most people are starting to feel fully recovered. This is a very reproducible surgery for pain relief. For many patients, they come back and tell me their pain is 0 by the time they get to that 3 or 4 month mark. I'd say maybe 20 to 30% report their pain as an occasional 1 or 2, where prior to surgery they were reporting it as an 8 or a 9. I would point out sleeping gets easier at night, and most people are comfortable sleeping on their back or their other side by about 3 months after surgery. You will eventually get to the point where you can comfortably sleep on the replaced shoulder, but even if everything else is going great, I find that being comfortable sleeping on the affected side all night takes about a year. I don't know why, that's what it takes, even if everything else is going great. So you'll probably get there, but that part is going to take a little bit longer, but you'll at least be comfortable sleeping on your back or your other side. So you can expect that you are going to keep preservation of that preoperative range of motion, and as mentioned, subtle improvements all the way out to 1 year after surgery. So just by way of summary, arthritis, it is a very common shoulder problem, whether it's in isolation or mixed up with some problems with your rotator cuff as well. An accurate diagnosis is the first step, including understanding whether or not your rotator cuff is involved. Initial management is always to prioritize maintaining function. And if you're progressively losing function despite attempts at physical therapy and doing your activities of daily living, that is actually one thing that might press you to actually jump the line and not try all of these other options for the next 6 months before you move on to shoulder replacement. Because if you are losing function, getting that back is less predictable than the pain relief. Many people do get additional function back, but you can't roll the dice on that as much as you can with knowing that the pain relief is going to be there. Assuming you're maintaining function, you really should try these non-surgical treatment options, oral pain medication and non-steroidal anti-inflammatory. Steroid injections are something to consider. I'd say maybe about 30% of my patients will try a steroid injection before they proceed to shoulder replacement surgery, but there are drawbacks, and we're beginning to realize more and more that the drawbacks are greater than we used to appreciate, so they should be approached with caution, and I would seriously express concerns if you're getting more than 3 injections in a 1-year period of time. Nutritional supplements are generally safe and reasonable to try, although the available orthopedic literature and medical literature out there, at least in the United States, doesn't clearly show any definitive treatment options that are going to work for you with respect to nutritional modifications. When it does come time for shoulder replacement surgery, preserve motion going into surgery. If you signed up for surgery but you're not going to get your surgery for another 4 weeks, don't tuck your hand in a pocket and just wait for surgery. Now is the time to really push. Make sure you keep that range of motion. No matter how hard no matter how much it's hurting you, you're not doing additional damage, and that preservation of range of motion is money in the bank that you get to take out after surgery. These are very reliable for pain relief. For the vast majority of people, they do improve function, although whether it's a modest improvement in function or a dramatic improvement in function varies from person to person. You will get less sleep disruption over time once you're a couple months into the physical therapy, and these consistently in the literature show high patient satisfaction scores when people are asked, you went through all this, was it worth it, would you do it again? It's overwhelmingly positive responses really whenever you look at outcomes for this at 6 months or 1 year after surgery, and that holds up for many years following the shoulder replacement. And I leave you with I believe the gratuitous, family picture, which flipped by quickly there, which is probably fine because my wife and daughter would be a little bit anxiety provoked by that. But that was actually my daughter at age 2.5 performing her first surgery on her favorite stuffy. I was sitting at dinner with her at a restaurant. She takes out her favorite animal. She lays it spread eagle on the table. She picks up her butter knife and she starts sawing at its leg. And I was like, what are you doing? She looks up at me and she goes, he's broken, Daddy, and I'm going to fix him. So it's one of my favorite pictures. Thank you for listening. Love to answer questions. All righty. So I'll just start running through these. So we have one from Carol who's on Facebook. That's great. We have at least one person on Facebook. I kind of figured that would be completely empty, but that's great. So what's the best thing a teenager can do for shoulder tendonitis? Well, so that's a great question. The best thing that a teenager can do for tendonitis is first make sure you have the proper diagnosis. The good news is for most teenagers and young adults who have shoulder pain, unless they have a specific identifiable traumatic event, the vast majority of these people can be properly taken care of and restored to good function with some combination of rest, time, activity modification, and physical therapy. The underlying cause of the tendonitis is really important. It can be anything from overuse for an athlete that is training too hard with their high school team, maybe spending too much time in the weight room. It can be related to the specific activity they're doing. Swimmers, golfers, tennis players, very common to get tendonitis because some of those shoulder motions they go through have a tendency to pinch the tendons, which causes inflammation. And so for those people, you may need to sort of take a look at their shoulder mechanics. How are they performing that? Maybe they need to rework the technique. For some, it is just that their strength between their competing muscle groups is out of balance. And so they need a physical therapist who can help show them how to specifically train subsets of muscles so that they can compete with the rest of the muscle groups around the shoulder, which are dominating and maybe causing problems. All right, so from Brian, I have a circumferential labral tear. Is it repairable with surgery? Vast majority of the time, yes. The labrum, which we really didn't talk about, is this ring of soft tissue that sits around the socket. It is part of the joint capsule that is immediately adjacent to the arthritic joint that we've been talking about, but right underneath the rotator cuff. So it's the one layer that's between the rotator cuff and the joint surface itself. And most of these are repairable. Most of these are repaired arthroscopically. Not all labral tears really require repair. A circumferential labral tear almost assuredly does, but people who get MRIs of their shoulder, almost all MRIs will call a labral tear. Most of those are incidental findings or some fraying of the tendon that doesn't actually require repair. But yes, those can be repaired arthroscopically, and certainly circumferential labral tears are usually profoundly debilitating and do need to be repaired. If you have a labral tear in someone who's, say, over the age of 50 who maybe has some arthritis, in that situation you're not going to repair the labrum because getting that labrum to heal in the setting of arthritis is not a viable option, but there are other treatment options for you out there. If you get to the point where you're 50, you have a labral tear and some associated arthritis. So Leanne from Facebook asks, what defines the state of arthritis, i.e. early or late? Yeah, good question that is just calling me out on sloppy mechanics, or sloppy semantics rather. I would call late arthritis that point where you have deformation of the ball. It's no longer, at least for the shoulder, where it's no longer the round ball that you're supposed to have, but it's changing into that egg shape where you have bone spurs and where you've got almost complete loss of the actual joint space. Early arthritis would be someone where you're starting to see the earliest hints of those changes, but you can still see a joint space. You can still see space between the ball and socket, so you're not yet rubbing bone on bone, but you can watch that joint space narrow over time. And as you get used to looking at a lot of these x-rays, you can tell, well, all right, that joint's not down to bone on bone, but that joint space is also not as big as it's supposed to be. They maybe have some small osteophytes, some small bone spurs that are forming around the edges, but they don't have those big ones like we showed in this talk here. So that's really how I define early and late stage arthritis. But that's always in the eye of the beholder. And I couldn't give you specific criteria that I'm using when I refer to those stages. Okay, Michelle, also from Facebook. Can you describe what to expect for recovery from replacement surgery? And then how much rehab or physical therapy and how long off work? Great. Okay, so good questions. So to sort of just fill in and review again sort of what we talked about in terms of expected recovery. I'm going to start with the easy one. How long you're off work depends entirely on what you're doing if you're at work. If you're a supervisor, if you sit at a desk job, if you don't have to use your hands for work, I would suggest you probably want to take a week off or so just because you're going to be sore. But after that, you can probably go back to a desk job and you'll be just fine. You're probably not going to be happy sitting at that desk for 8 hours a day. You're going to have to get up and walk around, move around some. But, you could probably take a week off and go back to it. If, on the other hand, what you do is drive a school bus or you have some other job where you use, maybe you stock shelves, you don't do heavy work, but you're stocking shelves and moving things around up here, you're going to be a minimum of 3 and probably 4 months before you're going to be reliably doing this, 8 hours a day. So how long you're off work really depends on what's being expected. But the good news is I think for most patients, if they understand the next parts of this question, that is how much rehab and what's the recovery look like, you can figure out for yourself how long you're going to be off work because you're going to know what you need to do at work and whether or not your employer is going to accommodate those, modifications you may need. So in terms of how much rehab and physical therapy you need, that's the second easiest question, because the answer is only as much as you need to get the job done yourself. I have patients who get a shoulder replacement who see a therapist maybe 2 times in their entire recovery process, because they're doing the exercises on their own for the first month. They see a physical therapist starting at 4 weeks. They get some exercises. They go do them for 2 weeks. They check back in with a therapist. They go do them for another 2 weeks. Then they see me at like 2.5 months post-op. And they're like, things are coming along okay. I know I still have exercises to do, but frankly, I saw what the therapist is doing. I know how to do this stuff. Can I just do it on my own? The answer is yes. So you don't need to see a therapist any more than you require that therapist to both make sure you're educated on what to do, and we make a point of trying to make these exercises fairly straightforward and not give you 20 you need to do. At any one stage, I'm only going to give you 3, maybe 4 that you really need to be focusing on, and if you know what those are and you can do them effectively at home, you may not need to see a therapist at all. Other people just feel like they want that support, need that support, maybe they need the motivation, and I do have some patients who will see a therapist twice a week for 12 weeks. That's by far the minority, but some people need and want that. And then in terms of the recovery from a shoulder replacement, the recovery, again, one night stay in the hospital for most people, you'll go home the next day. You'll spend about 4 weeks where a 1-pound weight limit for activities right in front of you is the activity level you want to stay at. You don't want to be doing any pushing, pulling, carrying, or reaching during that time period, but if you can do it down here with your arm, it's safe. After 4 weeks, you're going to be progressively allowed to try more and more activities. And some people get their range of motion back pretty quickly within 2 or 3 weeks and just have to work on endurance training. Some people are stiffer, and they may take 2 months to fully stretch out. So they're working longer on their stretching. They don't get back to full range of motion until 3.5 months. The recovery itself is going to take a full year, but most patients don't feel like it takes that full year. Most people feel like they're doing well by about 3 to 4 months. And then, the improvements after that are very subtle and progressive as they go forward. So Julie, also from Facebook, asks, at what point do you get shoulder surgery? And I think that's a tough question to answer out of context, because it ranges from everything from right after you're told in the emergency room that you have a break in your shoulder and the only way to put it back together is the broken bone. You need surgery in the next 2 or 3 days. Someone else has a nagging shoulder pain that's been there for a decade, but they've still got good range of motion. Their pain gets better when they take a non-steroidal anti-inflammatory. That person may be several years off before they need surgery. So, I think at what point you get the shoulder surgery depends on what shoulder surgery we're talking about. But if you're talking about a joint replacement surgery, I think the optimal time to get the shoulder replacement surgery is when you're at a point where you're noticing the pain is compromising your ability to do the things you want to do with your life, but you've not yet lost significant range of motion, and you have at least considered those non-surgical options that we went through. Exercises and physical therapy, a non-steroidal anti-inflammatory, maybe a steroid injection. And if you've tried those things and the pain is still stopping you from doing the things you want to do, then it's time to at least consider shoulder surgery if you're talking about a joint replacement and if you have a diagnosis of arthritis. Yeah. The people who really seem get those home run outcomes are those ones that still have full range of motion but pain related to their arthritis. And those people can come back to your office, and at 6 months they can do this, and if you don't see which side the incision's on, if you don't have their chart, you don't know which shoulder was replaced. So you can get those kind of outcomes with this. Interestingly, although those patients are almost always happy and although those patients look the best, the patients who often report the greatest satisfaction are the ones who come back to my office and on my physical exam don't look as good as I'd like them to be. They come back, they feel great, they're totally happy with it. You ask them to give them the range of motion, they go. But the thing is, they've been doing this for the last decade, and their pain has been so bad they haven't been able to do anything. And so their function doesn't look good. It's not the thing I want to put in my brochure. It's the thing when they walk out of the office and they say, "Thanks, doc," and they walk past all my other shoulders patients. I'm like, oof. But they're really happy because they got the pain relief that they needed, and this procedure is really good for them. Okay. When you do a partial shoulder replacement versus full shoulder replacement. So that is a great and nuanced question that I didn't even come close to because it is a tricky answer. So I didn't talk about what we call a partial shoulder replacement or a hemiarthroplasty. And a hemiarthroplasty is where you replace the ball but not the socket sides of the joint. The first shoulder replacements that were developed in the 1970s were a replacement of the ball but not the socket. For a long time, that's just what was done. Then they developed the socket, but the early sockets loosened quickly, and they always failed, and you always had to revise these shoulder replacements. And so for many decades, probably into the early 90s, there was always a real fear of putting in a socket, and so most people defaulted to putting in just a ball. And for people with bad arthritis, the just a ball works okay, but if you compare current outcomes for the just a ball versus the ball plus the socket, with the current technology, we've fixed most of those early failure problems with the socket side of the joint. And now, sometimes the sockets wear out, but that's the sort of thing that might be wearing out in 20 years. And if you look carefully at the ones that are just the ball, what eventually happens is you have a cobalt chrome ball riding on your own bony socket. Eventually, that hard metal will actually start to further erode your bone. And so there's a downside that didn't used to be really appreciated to doing just the ball side. Early on in my career, I did have a small select group of patients in whom I did just the ball. My experience, both in my own practice as well as looking at the literature over the last 5 to 10 years, has pushed me towards the point where I actually cannot remember the last time I did just a partial replacement, because I know the shoulder replacements where you do both sides of the joint are going to hold up a long time, and I know that the functional outcome and the pain relief is going to be much more reliable doing both sides of the joint. So I actually don't do the partial replacements anymore, even though I was trained doing them, and I spent several years early on after my training doing them. I've gone away from them because they're just not as predictable, at least not in my hands. Right. How quickly does the bone degrade with arthritis? And if you know you have arthritis, how often should you get an x-ray and check to see when should you consider surgery? Is it pain driven? So pain should certainly be a primary driver for surgery. How quickly arthritis advances is really unpredictable from patient to patient. We get some patients who seem to be really stable with arthritis for years at a time. Other patients can progress very rapidly. I would suggest that because it's not a good idea to get x-rays every 6 months of the shoulder, really what you should focus on as the patient is your level of function and your level of pain. If you're maintaining your level of function, if you're maintaining your level of pain, what the x-rays look like only has relevance when it comes time for that shoulder replacement. If you're deciding, or your surgeon is deciding when you're getting your shoulder replacement because of what the x-rays look like, then everyone's treating your x-rays, they're not treating you. The reality is, no matter what your bones look like in there, if you have acceptable range of motion and acceptable level of pain, you may not be ready for that joint replacement. Let the surgeon deal with whatever structural issues they have to deal with in terms of the bone and how quickly the arthritis is advancing once it comes time for the surgery. Base your surgery on the function and your symptoms. And as long as that's okay or you're maintaining it, I would suggest you're probably not losing much ground. Are there any techniques for improving sleep quality if you want to put off surgery for a year or so? Yeah, that is a frustratingly disappointing answer, which is pretty much everyone has a bunch of tricks. Not a lot of them work great. It's pretty much trial and error. Some people find that they are more comfortable if they have their torso propped up, so they're sleeping at like a 45-degree angle instead of all the way down flat. Some people find that what they really need is just one Aleve at night to get them off to sleep. Some people, I have had patients who tell me they've got, who I know have bad arthritis, but they actually are doing a little bit better because they started taking turmeric. I know nothing about turmeric except that I have a patient or two who eat it and they say they feel better and they're putting off their shoulder surgery. So no, I don't have any tried and true methods for improving sleep. It's a trial and error thing. But unfortunately, sleep does tend to be one of those things that pushes people to surgery. And I think one of the reasons it pushes people to surgery is that once you're having trouble sleeping, there aren't a lot of good workarounds. There just aren't a lot of other ways to get comfortable with it at night. And so that very quickly becomes a break point. Okay. If you have a complete shoulder replacement, is it possible to have nerve damage during the surgery where the hand is numb and the thumb won't move and is numb too? So it is certainly possible to get nerve damage during shoulder replacement surgery. The brachial plexus, which is the bundle of nerves that supplies function from the shoulder all the way down to your fingertips, actually runs very close to the front of the shoulder where we have to do this work, where we have to get in and out to do the shoulder replacement. So nerve injuries have been reported throughout the literature. Luckily, the incidence of nerve replacements, nerve injuries are very low, but they can happen. So, if you're having problems with numbness or weakness further down the arm after surgery, you should absolutely get that evaluated. You should absolutely have your surgeon know about that and have them work it up to see what's going on. It is also worth acknowledging that although a thumb that's numb and won't move wouldn't be the typical presentation for this, it's not uncommon for fixing the shoulder to unmask some other related issue that's not really directly related to the surgery, but the patient maybe wasn't aware of until they got the shoulder fixed. So for example, sometimes I'll have someone come back at 3 or 4 months after shoulder surgery, and they'll have a pretty clear-cut case of carpal tunnel. And the carpal tunnel is bugging them because now their shoulder pain's gone away and they're starting to use the arm more. And it's not that there was anything that was done to the nerve up here that's causing this numbness in the fingers. It's that they have carpal tunnel. But these things can unmask as you sort of go down the line. And so, those are things that you can have assessed too. Some people who have numbness after surgery, and this should not be a permanent thing, but was a comment on the sling. If you spend all your time in the sling, some people will get numbness in their small and ring finger, and that's because the ulnar nerve, which is your funny bone down here, runs right on this inner edge of the elbow. And the space for that nerve is constricted when your elbow is bent. And so if you live for 24 hours in a sling like this, that nerve will go to sleep, those fingers will go numb. That should go away as soon as you get out of the sling, but just one of those things to think about if you've had recent shoulder surgery or your arm's in a sling. Those fingers are going numb. Get your arm out of the sling, at least for periods of time throughout the day. Okay. Daryl asks if a frozen shoulder can lead to arthritis. And it's more often the other way around. So a frozen shoulder is a generic term that simply means stiff shoulder. It would be a lot easier if we just threw out the whole term, never used frozen shoulder again. Frozen shoulder is a stiff shoulder. The thing is, a stiff shoulder can occur for any reason you can imagine that a joint can be stiff, right? So you can get a frozen shoulder because you have arthritis and you have pain and inflammation and that friction across the joint. So that shoulder is stiff. That is a frozen shoulder. Your problem is the arthritis, but you have a frozen shoulder. And so in that situation, I would say, the frozen shoulder didn't lead to arthritis. The arthritis has given you the frozen shoulder. But there are a lot of etiologies of frozen shoulder. So someone can get a frozen shoulder after they have a rotator cuff tear, which causes them to have weakness and pain, so they shut down the shoulder and then the soft tissue envelope tightens up and scars in. That's a frozen shoulder. Has nothing to do with any arthritis. That person may have good cartilage on both the ball and socket sides of the joint. So any scenario you can imagine where you can develop a stiff shoulder as a frozen shoulder, it may or may not have relationship to arthritis, but frozen shoulder is rarely the cause of arthritis. Arthritis may be the cause of a frozen shoulder. And then How effective is same as adenosyl methinolone for joint pain. And, you know, I've heard some reference to it. I honestly don't know much about it. I think I would have to punt that question. It's not something I have experience using, so I really can't speak to that question at all, and I would not want to mislead anyone there. Okay. Can you wait too long to have a replacement, causing irreparable damage? So yes and no. The two scenarios where you can sort of wait too long is, one, I would suggest that if you had pain but full range of motion 6 months ago and you decided to hold off on your shoulder replacement and you decide now that you want a shoulder replacement 6 months later, and at 6 months your range of motion has gone from here to now you can only get your arm up to here, I would tell you that's a scenario where you have waited too long for a shoulder replacement. Because I may be able to improve on your motion from here, but the chances of me getting you back up to here where you were 6 months ago is not great. And even if I can help you do that, it's going to be a lot more work for you and a lot more work for me to get you there. And so that's a scenario where maybe you've waited too long. And it's not that the shoulder replacement can't be done at that stage, but your opportunity to get the most out of that shoulder replacement has probably been compromised because you let that function and that range of motion drop off. I shouldn't say let, you know, that's not fair. You can push really hard to try and keep the motion and it goes away anyways, but you know, you can miss that opportunity. The other scenario where you can wait too long, I don't know if you guys remembered it, but one of those slides I showed where the ball was starting to erode the socket and you're getting that scalloped loss off the socket side of the joint. There's not much bone on the socket side of the joint to work with in the first place in a shoulder replacement. And it's pretty easy to quickly lose any sort of a pedestal, enough bone to work with to put a functional socket on that side of the joint. And so one scenario where you will, either the surgeon will push you to surgery sooner and say, you know what, it really is time to get this done, even though you may be hesitant about it, is if you're seeing some fairly rapid bone loss. That means that the surgical options are beginning to be constrained. You're going to have to, now you can't use a standard implant, you're going to have to use a custom built implant that either the surgeon's putting together on the day of surgery, sometimes with bone that they're harvesting from other parts of your body to build back what you've lost, or you're going to an implant company and you're saying, here's my CT scan, they're missing this bone, I need you to build a custom titanium cage that's going to give me a support back where I don't have it here. These things can be done, but they're tricky, and they're always associated with a more difficult surgery, higher risk of complications, and those types of things. So if you're seeing significant, rapid, ongoing bone loss on either sides of the joint, that would be a scenario where you might wait too long to cause irreparable damage that's going to compromise what your options are as far as the surgical treatment. Okay, so I got 4 or 5 more. How long after surgery is the joint prone to infection? Good question. So the annoying answer is forever. It's foreign material sitting in your body, and your body is not going to reject that material, but as non-living material, it is always going to be an attractive surface for bacteria to glom onto and set up an infection. And all of us, every day, have infectious bacteria that circulate around through our bloodstream. When you brush your teeth in the morning, you shower your bloodstream with bacteria. When you stub your toe on the way out to the car, you gouge your nail bed into your toe, and you get bacteria into your bloodstream. And those will always preferentially attach to a joint replacement. And so as long as you have that joint replacement in, that joint replacement is always going to be at an increased risk relative to your own God-given native parts. However, the incidence of seeding a joint with an infection from another part of your body is nevertheless exceedingly low. It's on the order of about a 1% risk over time. And so it's small, it's manageable, and it's not something I would be worried about over the long term, but one thing you should keep in mind that I actually didn't mention here is that for involved dental procedures, not a cleaning, but say a root canal, if you have a shoulder replacement in, you should get a single dose of oral antibiotics at the start of that dental procedure because you're going to get a ton of bacteria in your blood at that point, and you should protect that joint. One dose of antibiotics is going to protect you. Similarly, if you're getting a colonoscopy, that's another place where you're going to get bacteria showered into your bloodstream, you should get a pre-procedure antibiotic in that setting. So I wouldn't be worried about infections over the long run, but it's something that, if you're going for minor additional procedures in the future, it's something to think about and ask your provider, either your orthopedic surgeon or the provider doing whatever procedure you're getting done. Either one should know whether or not you should have a protective dose of antibiotics to protect that joint replacement. Okay. And what are the risks for waiting too long for surgery? Well, again, I think this speaks to the risk of losing function that you might have had the opportunity to keep if you'd gone to the shoulder replacement, if that's the joint replacement we're talking about, a little bit sooner. That's really the main risk. And I'd say the only other risk is, lost years of quality of life. It's not that uncommon for me to see someone in clinic a couple months after surgery who tells me they wish they'd done it a few years ago. And so, there's that risk too. And, how do you quantify that? I don't know, but it's something to think about. Barbara asked, what about shoulder pain below the neck and above the area between the shoulder blades? Excellent. Yeah. So that is a really common place for people to have pain. And the reason it's common for people to have pain there is because if you have a problem with your shoulder, it's going to give you problems back here in your shoulder blade area. If you have a problem with your neck, it's going to give you problems back here. So you got two places that it can come from, either direction. If you have a shoulder that's painful or stiff and you don't have the range of motion that you want at the ball and socket joint itself, then in that scenario, what most people do to compensate without even knowing it is they start putting more stress and they start putting more functional demand on the muscles one link up the chain. And one link up from the ball and socket joint is where the shoulder blade sits on the back of the chest wall. And so you'll start overusing these periscapular muscles. And those periscapular muscles, because they're being worked too hard day in and day out, will have developed knots and tight muscle spasm. If all your pain is located back here, the good news is that it's probably not something that's going to require surgery on your shoulder. It may be something that's developed over time because maybe your shoulder's a little bit weak, or maybe you had an injury a year ago that's mostly recovered, but this part never got better. Most of that can get fixed with a combination of physical therapy, plus or minus things like acupuncture, therapeutic deep tissue massage will release those tight muscles back there, and that'll go away. But pain between the neck and the shoulder is really common, and most of the time it can either be treated non-surgically, or if it's a true problem with the shoulder or a true problem with the neck, when you address that true problem above or below the periscapular muscles, this stuff goes away once this part recovers. How long after surgery can you drive? Okay, good question. From a strictly legal standpoint, you can drive as soon as you're out of your sling and as soon as you're off narcotics. So, for some people, I'm okay with you being out of sling day of surgery. I wouldn't recommend it. I have had patients who drove 2 or 3 days after their surgery. Most people I find typically about 2 weeks is a good time to take off driving. After about 2 weeks, people are usually comfortable enough that at least to get to and from whatever activity they need to do, they can skip that dose of pain medication. And they can just rest their arm out of this thing where they're driving. And what you do is you rest your operated arm in your lap. You do most of the driving with the other side. I stepped out of the frame. There you go. You do most of the driving over here. When you need to turn on your windshield wipers, you can just reach down and stabilize the wheel at the 6 o'clock position with that operated arm. Take over, do whatever you need to do with the non-operated arm, turn on your lights, whatever, and then take back over. So I typically tell people about 2 weeks, but from a strictly legal standpoint, it's out of your sling and off narcotics. Last question I have here is, patient has arthritis, bursitis combined with a rotator cuff tear. What's reasonable to treat with prescribed physical therapy? for maximum improvement. Yeah. So, great question. Certainly tendinitis and bursitis should always be treated, at least to start, with 6 weeks at a minimum of physical therapy. Not everyone's going to get better with 6 weeks. If you're starting to get better after 6 weeks of physical therapy, I would definitely continue it because you will probably continue to see improvements beyond 6 weeks. And a lot of people, I'd say the majority of people with a truly isolated tendinitis and bursitis will get better over a 6 to 12 week period with some combination of rest, time, activity modification, and physical therapy. So that is absolutely the place you should start. Once you have a rotator cuff tear thrown into this, things become a little bit more difficult because not every rotator cuff tear is the same. So if you have a rotator cuff tear, almost by definition, you have a bursitis and a tendinitis along with it, because that just basically means that you have a tear with tendon inflammation, which is always going to be the case in the setting of that damaged tendon. And the bursitis is just inflammation of that lining that sits over the tendon. So when you have tendinitis, bursitis, and a rotator cuff tear, the real question is, how do you treat the rotator cuff tear? And rotator cuff tears can range everywhere from a partial thickness rotator cuff tear, which you see on MRI, but is not a through and through hole in the tendon. The analogy I give here is that favorite old pair of jeans you have that has that peach fuzz on the knee, right? If you look at that fabric on that knee with a microscope, you're going to see torn fiber cottons, or torn fibers of cotton, right? So technically, that's a partial thickness tear. There's tearing in that cotton. But when you step back and you look at those jeans, do they have a hole in the knee? No, they don't. So by MRI criteria, that's a rotator cuff tear, or at least a partial thickness rotator cuff tear. I would argue that for practical purposes, for you and me, for whether or not you need surgery, for whether or not you will respond to physical therapy, that's not a rotator cuff tear. But it's a common misconception because a radiologist uses different criteria to describe their tears than we do. And they talk about it on that detailed level because they're looking at those images. They may not be looking directly at the patient and the overall structure and the surgical need. At the far other extreme of the spectrum, you get some people who fall down and sustain an acute, massive rotator cuff tear that maybe involves 3 or 4 out of the possible 4 rotator cuff tendons. That patient should not bother trying physical therapy, because with larger tears and greater degrees of displacement away from where they're supposed to be attached, you can actually, over the course of even a couple of months, have degenerative changes that start to develop in those muscles that are attached to those tendons that can compromise your ability to ever surgically repair the tendon. So, unfortunately, the answer here to how much is reasonable physical therapy for maximum improvement with a rotator cuff tear is difficult to answer. But if I do need to get pinned in and answer it, what I typically tell people who don't have one of those big, scary rotator cuff tears that need surgery now, but do have a tear of some size that maybe would benefit from repair, but has the potential to get better with physical therapy, what I typically tell people is try 6 weeks of physical therapy. If the therapy is going to work, you're going to feel it start to work. If you do 6 weeks of physical therapy and you're not feeling any improvement, then physical therapy is probably not going to fix you. That doesn't necessarily mean it's time to go to surgery for the rotator cuff tear, but it means it's certainly time to move on to alternate strategies. So, and then maximum medical improvement, most people are going to max out by about 12 weeks to 16 weeks if they're benefiting from physical therapy. Yeah. So that's all the questions I have right now. Someone else? Thank you. Okay. Does the pain stay in the shoulder only, or does it go down the arm? Yeah, prior to surgery. Yeah, so Annette, great question. Actually, it's a perfect thing to hit on, because this is one of the reasons that there's often confusion between neck pain and shoulder pain. I'm talking about arthritis here and talking about treating this, and I tell you about all the pain here. But the reality is that I'd say more than 50% of my patients that have arthritis that benefits from a shoulder replacement also describe some degree of pain or intermittent tingling that will come down into the elbow, even the forearm, even in the hand prior to surgery. And for most of those people, that stuff goes away when we replace the shoulder. And the reason that this occurs isn't because this arthritis is referring down into the fingers. It gets back to that whole issue of shoulder blade mechanics and how they play into the neck. So if your shoulder is stiff and you're not using it properly, you overwork these neck muscles, these periscapular muscles. These periscapular muscles get tight, they spasm down. That starts pinching your neck. Your neck now has these nerve roots where they exit. And so the tight muscles in your neck where your nerve roots are exiting can actually get pinched here, causing numbness or tingling down in your fingers that you're not going to do anything here that fixes that, except that once this starts moving properly, this stuff's going to relax, and then the pinched nerve is going to go away, and this part's going to get better. So it's really common to have some degree of spread, either in the form of pain or numbness further down into the hand if you have a shoulder problem. I tell most people they can expect it to get better, but I also point out the fact that it's not an absolute guarantee. So I hedge my bets, because some people do have an intrinsic neck issue that just needs to be dealt with. So Kathy points to me and tells me I'm boring the heck out of people, so we got to stop. But I appreciate everyone coming. I appreciate everyone staying. If anyone has questions I didn't answer, I'm more than happy to stay around and talk with you after the rest of the crowd is dispersed.